20 to 30 minutes. So let's switch to
3,3
our other live case center. And it's so good to see the friends from Burdeux, many friends. So Thomas, we with you and with the whole Burdeux team.
Azim, nice hearing your voice again. So we're going to go quickly to the procedure. So we get the best of our 30 minutes, which are allocated to us. So the majority of you know the team from Burdeux, Lionel, of course, Julien on the echo, and Guillaume, our junior racing star. So I'm going to go straight to the case, but I'm not forgetting Valentine, our nurse, and the team from Gensker China who made the trip just for us. Next slide, please. So this is a case of a patient of 81 years old. Nothing particular in terms of cardiovascular risk. The most important part of her medical history is a severe COPD, which mainly responsible for not making her a good candidate for surgery. The TT showed a TR. I think Julian would describe it like Niagara Falls. It's more than a torrential one. And of course, we all decided together because of this severe annular dilatation and small anterior prolapse. So this is a combined, I would say, profile of the disease that she was a good candidate for transcatheter valve replacement rather than repair. Next slide, please. So nothing special in the tests that we have did preoperatively in terms of coronary angiogram and electrocardiogram. Next slide, please. And also the biological testing, as you can see it here. Next slide, please. Next slide, please. And next slide, please. The echo, we're not going to spend a lot of time on it again because we're going to commenting on the echo, and Julia will be much better than I do in describing the disease. Again, as I've said, the ejection fraction is still okay. The mechanism of this very important tricuspid regurgitation is mixed, both atrial and degenerative, having a prolapse on the anterior leaflet. The TREE score is low, so this patient is not a very high risk, and the Euro score 2 is at 8%, I think probably mainly because of the age and because of the COPD. Now, this is the LUX valve for those who are not familiar with. So this is a valve which was by design imagined and assessed to treat tricuspid regurgitation by displacement. The mechanism of anchoring relies on two important components, what we call the rabbit ears, which have to sit below the anterior and the posterior leaflets, and the septal anchor, which achieve the anchoring and stabilize the valve into the annulus. We will explain to you how the catheter works. The CT scan, what we look at, of course, the jugular access. So this valve demonstrated how easy is the jugular access, increasing the eligibility because of the friendly angle between the jugular access and the tricuspid annulus. The calculation of the annulus diameter or diameters showed that this patient was a good candidate for a 50 valve. The LUX valve have sizes that ranges from 40 to 70. So we can cover very large anatomies, but also small anatomies. So for this patient, we will be implanting a 50 valve. Next slide, please. So yes, we have prepared already. Can you run it? So echo puncture guided, 2 proglides or equivalent. And we used then over a super stiff wire, 3 successful dilators, as you can see it here. And then this will end up by inserting, you will see it how smoothly it goes through the neck. We will zoom on it later on. This short sheath, which is a 35 French diameter at still days. The next iteration and generation will be smaller. We have to predilate a bit the skin. So we are ready. We're going to switch now to the live case. We have the wire. We're just gonna use it to introduce the catheter into the right atrium, sorry. We have the stabilizer that you can see here, this metallic part. And then the catheter itself. Okay, so voilà. You see, I'm just pushing smoothly and delicately the catheter inside the right atrium. And then at this stage, we're gonna pull on the wire and we're gonna start flexing. Already, Lionel is doing this.
You can flex.
We overflex. Voilà. So, c'est bon. C'est pas grave, tu peux pousser un peu. Good. So we are in position. Can you zoom a bit on the catheter itself, please? Okay. Let's take out the wire.
Yes.
So vas-y, Lionel. So Lionel's gonna describe the catheter.
So we can move perhaps in good orientation. So we will work with the RAO view, 35-degree RAO and 10-degree colors. 35 And so on the handle, we have several handle to turn. And so the first thing is to go at the entrance of the RV. And we will start to flex the system, as you can see here. And we are helped here by the fusion between the transvagal echocardiography and the fluoroscopy. And so as you can see, we're probably a little bit deep. On est un peu deep.
Ouais, c'est surtout qu'il faut du flex. You need to flex.
Yeah.
So better.
Okay. So like this, it's better. And now we can advance a little bit deeper in RV. We had some flex again.
And septal. Go septal.
Yeah.
You are bending. Yeah.
So Thomas, you and Lionel, you're flexing to cross the tricuspid valve, and then you're going to try and get coaxial, correct?
Exactly. So by flexing, you go a bit also anterior.
Septal.
I think you just maybe stuck a little bit lateral there. There you go. That looks better. That looks much better.
Now we're good. Exactly. So
that looks better.
If you look at the echo screen, it's a X-plane, B-plane screen. You can see it. You have to be in the middle on the anterior posterior level on the left part of the screen, but also septal lateral. So we are a bit oriented septal, but it doesn't matter. We have to go into the RV first, and then we do the final alignment at the end. That's it. So now we're going to dive a bit more in the RV, and you can see it here very nicely, how it's self-adjusting. Good. So the movements are the same as you can do it with for a Vogue, for a mitral clip or Pascal. Clockwise, you go septal. Anti-clockwise, you go lateral. If you push the catheter in, you go posterior. If you pull on it, you go anterior. So this is the
it's flipped from femoral, right? Just the opposite.
Exactly, completely different. Yeah. So this is the 3D view also. So we're gonna then switch to the MPR exactly like it is here. So if you look in the green panel, we have a good anterior posterior position. We are also not bad septal lateral, but the global overall trajectory is more oriented septal. But again, we are not in position yet, so we don't pay a lot of attention on that. We're gonna dive. We have to go inside.
Voilà. On va le remettre. On manque de flex en derrière.
On fera à la fin.
Donc, j'ai mis tout ce que j'avais comme flex.
Donc, tu retrouves dans les antiseptales.
So, see, we are having, the more we advance, we fine tune, the more we are able to achieve a better axis and
A
trajectory.
little too posterior, maybe. Yeah.
Exactly.
But what is nice to appreciate is that you have these very subtle movements and manipulations, and you're not working over the wire, right? So it's totally different.
I want to go RV.
There is no wire involved anymore. It's quite
No.
an innovative concept.
I think at this stage, we still can go deeper if we want, just by pushing the valve itself alone, playing with what we call coupling or uncoupling. So now the next step is to be sure that we have enough depth in the right ventricle. Julien's going to try to assess this. So we recommend something between 3.5 and 4. Although this valve in some patients is very forgiving, and we can start higher or deeper. It doesn't matter.
Yeah.
So again, for the audience, similar to what we saw with Evoke, the concepts are similar. It's maintaining coaxiality, being really positioned in the center of the valve with a good trajectory. So facing, again, a perpendicular line straight down. And then, whereas with the Evoke, we saw the multiple anchors. This has these two bunny rabbits now, bunny rabbit ears, they're called, which are just little two anchors that have to come out and be below the leaflets, so that they go under the anterior and posterior part. So that's what the team's looking at. They're looking at the trajectory, the position, and then the depth is important so that when you open, you're not too deep, but you're not above the leaflets either.
So Julian is going to calculate the depth, and the depth is important because once we start deploying the valve, we just have to be sure that the rabbit ears will open below the leaflet. However, if it happens that you are above higher, with this valve, by using this coupling mechanism, you can still push it down, or you can even recapture it. So it's very forgiving in some particular challenging anatomies. So what was the depth, Julian?
3 centimeters.
Okay, so we have to go a bit more deeper now. Yeah, we can use the coupling at this stage because we have a good trajectory. And you can follow it on the fluoro. If you look at the fusion, turn to the system.
Thomas, is there any risk of getting caught in subvalvular apparatus like the Evoke, or no?
No, because you can recapture it. Absolutely. Yeah. I mean, if you have a bad trajectory, you may be entrangled, but with this valve, you can get rid of it easily.
3.3 centimeters. I think it's good because we are deep enough.
Yeah, and these two rabbit ears are very soft. And if you just open the rabbit ears and nothing else, you can just close them again, recapture, come a little high or go a little deep and open them again. You're going to watch them open.
No.
Because that's always the issue with the Evoke, right? Which is, are you too deep? Can you get away?
Absolutely.
And so it looks like might be a nice advantage here.
Yeah, Julien.
Yeah.
So one final check of the depth.
It's a little bit difficult to be sure.
So the echo doesn't have a good window today, as you can see it, but I think we are good enough.
I think you're good also. I mean, also the fusion's useful. I think it gives you a sense that your rabbit ears are below.
Okay. So we're not going to go deeper. We don't need to go deeper. We're going to start unsheathing now. And if you look at the fluoroscopy, you just pay attention on it, you will see these two longitudinal ears, which are going to get horizontal. So we're going to open them till we get perpendicularity to the device itself. And then we will reevaluate the position. Okay. And look, by doing such, you're uncovering the valve. You start seeing the septal tongue. It's really like a tongue facing us. And these rabbit ears getting freed. Okay. Okay, good. We stop here.
Yeah.
So Julian is gonna describe this now, and he's gonna tell you what he's looking around for. So he's gonna distinguish clearly the rabbit ears from the leaflets, one on the posterior side and one on the anterior. And if we are at the level of the leaflets a bit below, that's fine.
I think we need to be deeper because
Okay.
we are just on the here.
Yes.
You can see.
Yes. Okay.
We are just
The posterior there. Yeah.
Yeah. So we are using this coupling mechanism where we are pushing the valve inside without changing the trajectory.
Non, je fais.
Okay. Julien. Yeah. Okay.
So is there a minimum
so
ventricular depth that you need for this?
Yeah, we need usually around a 3.5. You mean for the rabbit ears with the leaflets?
Yeah, and
Is this the question?
The depth to allow for the capsule or whatever. To push it forward now, you need more depth, right?
Yeah.
you are a little bit too posterior. I cannot see the.
Yeah, I think you're very posterior and you're pushing maybe on the rabbit
Exactly.
here. So maybe, pull the whole system back a bit, get more central. So you free it up.
Exactly.
And a little bit more septal.
So Adam, it's a good question you asked. We involved in the early feasibility study. I must admit, we've not had a rejection based on ventricular size, because generally if you have about 3.5 to 4 centimeters, you can do the case. The fact that there's no wire here, that nose cone is like super floppy. So even if it's touching the apex, it's not going to cause any damage to the ventricle or perforate, because it'll just get pushed away. It's extremely floppy without the wire. You can even see how on the floor it's moving away. It just moves by itself.
Okay.
And the other advantage of this technology is they have the biggest annular size just close to 70. So they have a 70 millimeter valve. We mostly implanted the 60 and 65 in the EFS, but the EASE is 72.
So
This way.
okay, you see, we are just trying to gain some height, and you see we are below the leaflets now. Julien?
Yeah. We are below the leaflet here in posterior.
So what we did, we recaptured a bit, and so that helped us getting a better access, and then we advanced the whole system. So you can see, Julien, you can just talk about it if you want.
Yeah, on the green window, you have the posterior part of the rabbit here, and on the red one, the anterior one. So the leaflet are just below.
Go a bit deeper. Yeah. Azim, what do you think? A bit more deeper, or that's fine?
Just a little deeper. The posterior looks very good. I see the leaflet above.
Yes.
I'm struggling with the anterior. It's a little difficult to see, but I trust Julian. If he thinks it's above, I'm happy.
Yeah, it is above. It is above.
Okay.
And if you look at the fluoroscopy, they are almost in the final position, not completely. So the likelihood of that they get shorter is lower,
Can you, just for the audience and for everybody, mag up the fluoro just for 1 second so everybody can see the septal tongue and the two rabbit ears? Are they moving?
Yeah. Okay. Cine. So Guillaume's gonna show you what are the rabbit ears and what is the septal tongue. Vas-y, sorry.
So is the one rabbit ear still inside the system?
No, both of them, Azim, are outside.
They're both out? Okay. Okay.
Yeah, they're both out, and you can see it very clearly. Otherwise, they will not be in this. They will not get the same shape. And I mean,
Got it.
here the echo shows us nicely that the difference in height that we can see between the right, the red panel and the green panel on this MPR construction is due to the fact that the valve is not fully in a straight axis. But this is not an issue with this valve. You don't have to be 100% orthogonal.
Okay.
I'm happy with the position. Yeah. So if this is the most important step of the implantation, actually, because once you have this, you're almost done. So we're going to continue now. Okay.
Yeah.
Vamos. So quickly now, we're going to complete the deployment. So, wow. Look, watch it on the fluoro. Good. Till the hard stop. So Lionel is completing the deployment till what we call the hard stop. Then we'll check on echo. You see we have a good position of the device on the echo at the level of the annulus. Julian is going to assist this. The valve is functional now.
Yeah, it looks
And
really
you see
good.
how the hemodynamic is stable.
And also you see the gravity is very easily now. They're well positioned. They're moving with the annulus and the leaflet.
Yeah.
And it's well applied, even in posterior part.
It's good. Yeah.
Sometimes
really
the posterior
good.
part is touchy, but
Yes,
now it's
exactly.
okay.
So one of the particularities of this valve, it's super flexible. It doesn't rely in the anchoring on oversizing. It's super flexible. And this is also probably why with this valve, we have single-digit pacemaker need after the implant.
Right.
So Julien, so you see, we're not deep.
Yeah.
So first
Julien, you want
of
to...
all, we do the rotation.
Yeah,
There's no PVL, it's okay?
no PVL, no PVL.
Okay. So what we're going to do, if you look at the fluoroscopy, we're going to optimize the position of the valve by rotating it. The idea is to bring the septal tongue in the middle of the nose cone. And why is that? Because this is the view that we are using is really the view that helps you being parallel to the septum. And this is what Lionel have done. You've seen it?
So he rotated the valve very slightly, right? So that the tongue, the nose cone and where the Y lumen is sitting in the middle of the tongue, right? And just for the audience,
And you can see it
you're
here.
looking straight onto the septum now, onto the interventricular septum. So imagine that in front of us,
Exactly.
flat in front of us, is the interventricular septum between the right ventricle and the left ventricle.
Yeah. So now the next step is to assess the contact between the septal tongue and the septum itself, because this is where we're going to terminate the implant by using the needle, which is going to hold and attach the septal tongue to the septum itself.
Thomas, on leur montre ça.
Yeah, oui, parce que dès qu'il nous dit, ah oui. Okay.
So now you're pushing a microtube down onto the septal tongue, and this microtube contains the septal anchor, right?
Yeah, so now what we're doing is, so Lionel is turning a knob. This knob helps you pulling on the stitches to be sure that there is no, in the catheter itself, there is no interaction between the stitches and the inner core of the catheter. And now he's ready to fire, I would say. So the shaft where the needle is going to be pushed by Lionel.
Ok. Fluoro, graphie peut-être.
You can push a little bit more subtle to have a better contact.
Right.
Yeah.
C'est bon, Julien?
Ouais.
Yeah.
Là, on a...
Okay, Julien.
Yeah, it's okay.
Okay, good.
Allez, graphie.
So this is the needle shaft. You see it? we are pushing it because this is the tunnel through which the needle that will attach the septal anchor to the septum is gonna go. And you can see on the echo, look, Julian, can you explain on the echo what you're saying? How beautiful contact we have.
We can see here the tongue, again, the septal part, and we have a small deformation of the septum that we want to have during the procedure to be sure that the contact is good for the anchoring.
Azim, you happy with this?
Yeah, it looks really good.
Okay, so now this is the final step. So we're gonna fire, as we say.
Can
So
we
this is the
back
needle.
up the fluoro for this so everybody
Yes.
can see the anchor?
Yeah.
Thank you.
Yeah. We're gonna make up the fluoro, and we're gonna make up the camera on the fingers of Lionel. Show you the. Okay. Non, un peu plus là. Ok. Tu peux zoomer un peu plus, s'il te plaît. Ah. Ok.
Pousser.
This is okay. Okay, good. So, on y va?
Oui.
Bon.
Graphie. Pas trop longue.
Okay, good.
Oh, wow.
Yeah.
So you see, yeah. Tu peux agrandir.
Okay.
So we're gonna release the needle now.
On peut zoomer pour voir les angles.
So we're gonna magnify also, Azim. So we show you the needle. You see? Tu peux le remontrer? So these are 3 arms needle.
Okay.
Good.
Je vois pas moi,
Yeah.
ils en sortent un.
Tu tournes et tu tiens. Vas-y. Voilà. Good. Fluoro.
It looks great.
It does.
So maybe Thomas,
Can you assess? Yeah.
to release it, and then we have to go back
Yeah.
to Philip, who's waiting to show us the echo.
Yeah, sure. Yeah, we are
Looks beautiful,
finalizing.
guys. Congratulations. Really amazing.
Good. You see, so the needle is detached.
Yeah.
So while Lionel is gonna release it, Julian's gonna show us the echo. Okay. And release.
And in 2D, we can see that there is no paravalvular leak in the anterior part, in the posterior part. You can see on the 3D view. The device is well applied and there is no paravalvular leak.
It looks beautiful.
Okay.
Yeah.
Yeah. So if everybody is happy, perhaps we can do the final release. So Guillaume, on va faire ça sous graphie. On reste en 3D.
Wait.
Ouais.
Let's go. Tu l'as. Oui.
Voilà. Ça y est.
Okay.
Stop graphie.
Good.
Okay.
On va prendre un
Looks
champ plus
great,
large.
guys.
Yeah.
Amazing. 30 minutes.
So-
and you did a
So now
trapeze valve replacement.
we're gonna flex. Now we're gonna go RA. You see, the valve is completely detached. Vas-y,
Mhm.
Lionel. Voilà, on y va. Vas-y, Lionel. Voilà.
Vas-y, un
Tout
flex.
doucement. Vas-y. Voilà, voilà. OK. Maintenant, vas-y, recapture.
Yeah, looks great. Wow.
Yeah, now we're done. So you see we finished.
Attends, faut capturer, je pense.
Thomas, Lionel, Julian, everybody in the nurses, everybody in Bordeaux, thank you for a phenomenal case. That was incredible. Fantastic result. Congratulations, really. Merci.
So we're done. Thank you very much. Good luck
Amazing.
for mains.
Good job.
See you guys.
Bye.
Au revoir.
Bye bye.
Merci. Thank you so much.
Au revoir.
Good job.
Impressive.